handle 1/4 turn is 60 microns and 1 full turn would be 240 microns. Coming to suturing techniques in penetrating keratoplasty, which is the advanced? This one? Yeah. Well, if we look at the original corneal transplants, when the circular trifines were not there, even the square grafts used to do very well. That's Raymond Castrovio, and that's his square graft. And some people have reported, at least on the discussion group, that they have seen square grafts, clear for 25 to 35 years and then fail later. And these were sutured using silk suture, and sometimes just with 4 sutures. And this silk used to bring in the healing very fast. And within few weeks you could remove the silk suture and everything would be fine. Well, this is what the standard steps of penetrating keratoplasty, what Ashish had given nicely in his presentation, and this need to oppose the cut ends properly so that you attain a watertight closure. You induce minimal astigmatism. You maintain a clear corneal graft in the post-operative period, and you should avoid any kind of complications. What are the suture materials that we use? Most commonly we use 10-0, at least in my practice, most commonly it's 10-0. Very rare situations do we need to use 9-0 or very rarely 11-0. The suture that we use is basically nylon, which is most popular. It has very low tissue reactivity and it's very easy to handle. It's about 26% elastic. So, and the only disadvantage is that over a period of time it undergoes hydrolysis, and so in a year and a half later you can see the sutures degrade and they start to break. Prolene has also been reported. It is less elastic and does not have any impact of hydrolysis. However, it's not very easy to handle, and I'm sure for people who do scleral fixation IOLs, you can understand that when you handle the prolene suture or you suture the iris, it's not like nylon. The other suture is mercilin or polyester, which our retinal surgeons use while doing scleral buckling. It has no elasticity, does not have any effect of hydrolysis, but the only problem is that it has increased tissue response, and they are very brittle, so while suturing and all, it can break very often. In terms of 10-0, what we commonly use, 9-0 or 8-0, sometimes you may use in therapeutic penetrating keratoplasty when you want the wound to be really secure. And 11-0 is sometimes in combination along with 10-0, where you want to retain the 11-0 for a longer period of time after removal of the 10-0. The needle, yes. What needle we use is commonly the reverse cutting spatulated needle, which cuts in a fashion like this, so it basically goes through the corneal lamella without distortion. The other needle points that we have are the round bodied or the triangular or the reverse cutting, and this is what the spatulated needle looks like. It has a curve. The common needle that the 10-0 spatulated, what you get from Ethilon is 140 degrees, but you can have needle from 140 to 180. That means nearly from 1/3 to half of a circle. The other needles which are available are mini curve, bicurve or multi-curve, and some of them have use specifically when you want to minimize the cord length of your suture. Supposing wound repairs, if you want to do in the cornea and you want to take very small bites but very deep bites, then you may use mini curve or multi-curve needles. So basic suturing principles: your suture should be at least 90% depth for interrupted sutures, although people have also described full thickness sutures, but full thickness suture in my opinion may not be watertight. Sometimes through the suture tract, because of slight cheese wiring, you can have leakage of aqueous. And when you're doing a continuous suture, because the continuous suture there are no gaps between the sutures and it's a continuous traction, you can afford to have at about 60 to 75% depth of your incision. Suturing direction usually is always radial, except when you are planning for no torque suture, which I'll be coming on to. And the normal principle that I follow is initial, it's a 3-1-1 knot, and but you can use it even a 3-1-1-1 or a 4-1-1, but this is the one which is easiest to manage. This is something that you should avoid. This is called a lambda effect. That means if your suture that you tie, if it is superficial and if it's not going all the way 90%, when the suture is tied, there is posterior gaping, and then this basically your wound is not very secure, and this remains a very weak point of your wound. So this should be avoided. And this also, when after suture removal, it induces a lot of astigmatism as well, which is often unwanted. When you place the donor tissue, you should not go ahead and start suturing immediately. Sometimes you put your donor tissue and you can rotate it clockwise or anti-clockwise, sometimes to get the optimal fit into your circular wound. And if you have an intraoperative keratometer on your microscope, you can see the reflex, and when the reflex looks most round, that is the point where you can leave the tissue and start suturing. The other way to orient the graft is to have those 8 markers, so you have some sort of indication as to, the initial 4 or 8 sutures can be placed much better. The most common or the initial technique that you should start with is the interrupted suture, and it's often called the primary suture technique. The suture should be radial, 90% depth, constant length and tension. You require anywhere between 18 to 24. If you're doing a very small graft, in pediatric cases, sometimes a 6.5 or 7, then even 12 sutures would be sufficient. But on a 7.5 to 8 millimeter donor, you need about 16. But if you're going larger than that, like a 9.5, then maybe you need 24, because the circumference is much larger. Interrupted sutures are basically indicated in pediatric cases, in vascularized corneas, and patients with ocular surface disease, which may include patient with allergic eye disease, or if it's a slightly inflamed surface, as in infections, or patients having some component of dry eye. The biggest advantage is that it allows you to selectively remove the sutures as they become loose or break, which may not be possible in the early post-operative period with a continuous suture. The disadvantage is, it's not exactly a disadvantage, but it does take a little more surgical time as compared to a continuous running suture. There are a lot of knots, so some people feel that there is increased reaction, so each knot has a tendency to bring in blood vessels into the graft, and you really cannot manipulate sutures as easily as what you do with a continuous suture at the end of surgery. Although you can have an intraoperative keratometer, look at the reflex, and then you can remove the interrupted suture and replace them, but it's a little bit more cumbersome. And if you look at that, just to show you in animated diagram, and what Ashish was showing you, this is this is called a Pollack forceps, and it has 2 prongs, and basically what it does is it stabilizes the tissue much better. And for corneal surgeons, you will realize that sometimes the most difficult suture is the first suture, because when you try to hold that with a forceps and you try to pass your needle, your needle does not follow the right path, and often the tissue gets distorted to one side or the other. But if you have this forceps, it makes life much easier, and you're able to place the needle to the desired depth, and you can attain very good suturing. You place the first suture, and when you this, according to me, this is the most important suture when you do a corneal suturing. The first suture is fine, and this is not often the best suture. So what we do is we always replace this suture at the end of surgery, because when you are placing this suture, there is no support on any side, so the amount of tension that you have in your suture is not going to be the ideal. So we just place the suture. Sometimes we leave one end longer so that we can identify that this was the first suture that we placed. Once you place the suture on the other end, you can see that it bisects. It's equal on both sides with equal amount of gap. And then once you put the other 2 sutures, it should form a square diamond configuration, which tells you that your tissue distribution has been equal all around. You place 4 more sutures, and at this point you can take any circular instrument like a Fledinger ring or one of the forceps which has a round opening on the handle, and use it against the reflex of the microscope to see what kind of reflex you're getting. If you feel that your reflex is not circular, it's oval, then you can cut with the tight suture and you can replace. Then just to show you what an interrupted suture graft looks like, and again in the early post-op, if these sutures become loose, you can remove them without having to compromise on the integrity. This is something again that sometimes you can use. It's called the slip knot, where that's a single knot. It's put in this fashion, and this what it allows you is that if you put 4 of them, you can actually loosen or tighten these slip knots till you get the desired reflex, and then you can put 2 more throws on top, and that kind of locks the knot. It's good, but it takes up a lot of your time, and each suture has to have long ends for manipulation later on, so sometimes it can become a little confusing on your surgical field. Continuous technique, Yes, a single radial suture, you initially put 6 or 8 interrupted, and then you take a 16 byte radial at 90% depth. It allows adjustment. The disadvantage is that only one knot is holding the entire suture, and if it breaks while suturing, or then it's quite cumbersome to again rejoin a suture.